Welcome to AO meeting. We're talking about basal joint arthroplasty or thumb basal joint join. Since I forgot a letter, we have an incredible faculty and sage here. Brent Bamber from Dayton, Ohio, going to talk a little bit about introduction and then into implant arthroplasty. We have Dr. Martineau, a friend and colleague and partner in Dayton, Ohio, with Denervation, PRP, and other things. And then we bring up the superstars, one from NYU and one from Mayo, with Dr. Paxma and Dr. Kitty Wu, that'll talk about the touch prosthesis and moving forward. They've all been having their disclosures. We try to make this completely independent. We're not try to hook exactly to any implant company. So we're trying to show what we're trying to do is to follow up and look at the quote standard, which is trapezium LRTI or suspension plasty. That was the session one that was built. The objectives for this one are say, all right, that's not the best way to do things. Are there other ways of skinning a cat and trying to take care of people's basal joint arthritis? We've got a lot to cover. We'll just kind of move through with some general topics from just welcoming as you're getting now to PRP, then into implants. Dr. Paxma, Dr. Wu will bring the superstars at the end. So there are other courses that we have going. In July, it'll be sort of the third part of this, where we're looking at a journal club, looking at basal joint arthritis, and then we move into complex hand fractures in August. So please join us for those. Other on-site courses is one out in Seattle, hand and wrist one. We just finished the same type of meeting up in Ann Arbor. And there's the fellows course that we're developing out in October, looking at all different possibilities. So, why are we reconsidering this? Well, we had a couple people talk about Dr. Lawton and Blazer and Dr. Pitts talking about all the reasons why the regular basal joint arthritis works, but subsidence is kind of accepted. Pinch strength is just not there. And it's really difficult to revise one of these once you do it. So, what are we going to look at? Well, you get hyperextension of the MP joint, you get radial nerve problems. Well, you get that with just about anything. And, hopefully we're not going to have problems when we talk about denervation. We have how long does recovery take? We always hear people takes long when you take that bone out. So are these really good results? So as we move forward, our Act 1 is going to be do PRP, denervation, little viscosupplement, just looking at other ways to take care of the problem. I'll slide into some things looking at silicone spacers from Dr. Swanson, so I got more gray hair than these guys, and sliding into some of the newer implants, which are trying to progress for the same reasons, and I'll try to explain why we think that's good. And then at the end, as again, we'll have NYU and Mayo with Dr. Wu and Dr. Paxma to talk about the CMC total joint. So we are going to stop share if I know how to, and if I can show, we'll move on to Dr. Martin now.
All right, so thanks, Brent, for inviting me along. Just some objectives for my side of the talk. We're going to identify some of the steroid alternatives to treat thumb CMC arthritis and their efficacy. And then the important about thumb CMC denervation is describing the anatomy and I think experience with the technique to try to achieve an optimal result, and then incorporating these into your CMC treatment algorithm. We'll start with indications, move on to briefly viscosupplementation as well as PRP, and then spend some time on the CMC denervation. And so for steroid alternatives, we're talking hyaluronic acid, we're talking platelet-rich plasma. There are others, but it's beyond the scope of this talk because I have 10 minutes to go over this. Indications, Eaton stage 1 to 3 arthritis. These patients are interested in delaying or avoiding surgery, and they have a particular either dislike or distrust of steroids, or may have had steroid injections in the past and wanted to try something different. The denervation, a very similar kind of patient population, failing conservative management, and as opposed to the gold standard, these folks may desire a quicker recovery, and they're coming to with a painful, mobile, and stable joint. So we jump into viscosupplementation. Hyaluronic acid is a naturally occurring sugar molecule in the body. It holds 1,000 times its weight in water. It's designed as a lubricant, used primarily in knee osteoarthritis. They come in 1, 3, or 5 injection treatment therapies, and they're billed as something that provides longer relief than steroids. And do they work? So the hyaluronic acid is not FDA approved for the thumb CMC joint. Some studies are mixed. You'll find studies that show uh, no difference from placebo to those who provide improvements in pain longer than steroid injections. So Fuchs et al., they had 88% relief in the hyaluronic acid group versus 79% in the steroid group at 26 weeks. There was a single-blinded randomized controlled trial looking at patients on steroid versus hyaluronic acid. They all improved your pain and functional scores, but it seemed that if you had worse scores at baseline, then the hyaluronic acid led to greater improvements. And so this all seems well and good, but the bottom line's coming up, so just stay tuned. Platelet-rich plasma, it's regenerative therapy, again, built to possibly last longer than steroids. Um, the science behind this is a lecture in of itself, but when you spin off the platelets from the blood, they're full of growth factors. They can have different concentrations of platelets, different concentrations of leukocyte counts, and the PRP literature loves to kind of dive in deep into those details. We'll just providing it here for some context. And there was evidence looking at this, 2025 systematic review. There were 7 studies accumulating with 115 patients, and 3/4 were satisfied at about 14 months. There was improvement in pain, pinch strength, and no adverse reactions. There was a Mayo series that demonstrated roughly 70% moderate to excellent improvement with PRP at a mean benefit of almost 16 months, which is pretty good until you look at review that Krez did, looking at 10 studies, mean follow-up was 6 months, and it was steroid versus alternatives is what we were talking about. And there were similar improvements in pain and functional outcomes. So when you consider the cost and the ease of the treatment, they favored corticosteroids. And so bottom line, steroid alternatives, they're safe, they're efficacious, but they can be costly. And so in my practice, it's where a patient wants to avoid steroid or if it's failed steroid but don't want to move on to surgery. And if that's not working, this is where you can consider CMC denervation. Historically, Kamitz was the first physician to introduce the idea of a denervation procedure, but it wasn't until Wilhelm in 1965 who popularized it for the wrist, and Cozy demonstrated a technique in 1991 for the CMC joint with multiple revisions driven by outcome and anatomy. And apparently, I think that's Dr. Kamitz, but he's a hard man to find on the internet these days. All right, advantages of CMC denervation. You have no postoperative immobilization, a shorter recovery time, costs both based on surgery time as well as implant costs, which there are none, and your time off of work lead it to being, I think, one of the most cost-effective surgical options for this condition. And it does not compromise further surgery. So the anatomy, Tran et al. Did a beautiful study looking at cadavers with schematics at the innervation of the thumb CMC joint. And for reference, the slides show the asterisk of the thumb metacarpal base, and the branches that most studies concern themselves with as far as for pain relief are the superficial radial nerve, the terminal branch of the lateral antebrachial cutaneous nerve, and the palmar cutaneous branch of the median nerve. But several studies, and again, the anatomy is kind of mixed on percentages of these nerves and innervating the joint, but you'll also get contributions from the deep branch of the ulnar nerve, the thenar branch of the median nerve, and this dorsal articular branch of the first dorsal interosseous. And so here's just a lateral view of the cadavers with a schematic, and you'll see in the orange and red colors, superficial branch of the radial nerve coming in dorsally, your lateral antebrachial cutaneous nerve, again, more palmarly. And then when you look at these palmar specimens, again, you'll see the contributions from the lateral antebrachial cutaneous and the palmar cutaneous branch of the median nerve highlighted in pink. And I just think the difficult part, or the potential for need for revision, comes from the slide here, in my opinion. It's looking at these sort of deeper, more ulnarly based or medially based nerves, thenar branch and deep branch of the ulnar nerve, that come in a region that's very difficult, if not impossible, to get to unless you're taking out the trapezium. So we'll touch on that later. So the technique, again, multiple different techniques, one incision, two incisions. The one I've adopted is demonstrated here. It's a 4 centimeter Wagner approach. You get down to the thenar fascia, and then you start the thumb metacarpal and dissect over dorsally and ulnarly to the second metacarpal base. And from there, you slide proximal to the distal radius. And you'll see these little branches of the superficial radial nerve coming off. And you'll just, anything, I tell our residents and fellows, we're teaching anything that's perpendicular to the plane of surgery, you want to cauterize it or clip it. Now you got to be careful because these branches of the radial nerve are very, very short. So you can't safely do an actual neurectomy. You just have to cauterize it or divide it, because any attempt at full-on neurectomies will start damaging the traversing superficial radial nerve, and you'll get hyposthesias, which is a common complication. Your dissection then carries down to the anatomic snuff box. Here, you'll find the terminal branch of the lateral and brachial cutaneous nerve, and on the image on the right. The way I'll approach this, you'll most often find that branch on the palmar side of the first dorsal compartment muscles. Excuse me, they're tendons. But I'll carry my dissection that we started dorsally all the way up to basically the anatomic snuff box. You'll dissect the radial artery away from or off of the capsule, and there occasionally have been found branches dorsal to the first compartment tendons, so I'll divide those. And then you head palmarly, and here's a good picture of that branch there. And then finally, as your dissection carries you more palmarly and then ulnarly, you'll want to elevate the thenar muscles off of the origin, and then you'll want to try to get as far volar and ulnar, sort of around the corner, around the capsule, to try to reach as many of these medially occurring nerves to make sure you can complete your denervation. And I'll treat this almost as just like a capsular denuding. You want to make sure you get any tissues that's coming in, attaching to that capsule, off and elevated, and to ensure your denervation is complete. And so in the real world, as pulled several studies that are often quoted looking at thumbs, outcomes, and satisfaction rates. One I thought I would highlight is Weir in 2026. This was a review of data from basically a database looking at 540 denervation surgeries, and then they matched that from this database with the trapeziectomy group and looked at their outcomes. And it was interesting to note a lower reoperation rate for the folks who had denervations than those who had trapeziectomies. And so although this doesn't burn any bridges and you can always do an LRTI later, according to the recent data, less people having reoperations with denervations than trapeziectomies. But again, that's one study. The rest show, again, anywhere from 3% up to 28% reoperation or failure rates. And just a couple more systematic reviews. The most common complications, radial nerve palsies or patchy hyposthesias. So I consult my patients often, like I do if I do a distal biceps, say you'll often have some numbness and tingling with distal biceps surgery in that lateral and brachial cutaneous region. You will often get radial nerve, superficial radial nerves, hyposthesias after surgery, but they often go away. And then patient satisfaction rate, again, highly satisfied from the literature review, but they did their own pilot study, and their outcomes were unique in that the pain that patients experienced with activity improved, but the rest pain did not. I've not seen that in my practice, but I include it for completeness sake. And here's your one of a couple studies that looked at recovery rates, comparing denervation with LRTI, 3.3 weeks to full recovery versus 4.5 months. And so there's a huge potential advantage there. and it seems to be gaining traction, although what we're talking about here in 2025 represented 1% of the surgically treated thumb for CMC arthritis, more often seen in the Western US, which we have nobody from the far West here. I was hoping we get some feedback from the audience. Males, and then age was not a factor. And for completeness sake, you can do these wide awake. And so for folks, again, I've seen described other CMC surgeries wide awake. This one's relatively straightforward. Patients that are more medically complicated, that's a consideration for you. There's literature on preoperative nerve blocks versus not. Again, the literature's out on whether that's useful. The radiosensory paresthesias we talked about. If you have instability or Eaton stage 4 diagnosis, this is not a recommended procedure. There is too many dissatisfied patients in those two groups. And so take home, if you're looking to avoid surgery, you can try these non-steroidal injectables as an alternative, but they are costly. The denervation is a go-to for a painful, mobile, stable joint patient who wants to get back to work quicker, who's also failed your standard care, non-operative options. And from a value-based care standpoint, it's hard to beat. So that's my talk, and I will give it back to Brent.
The one question in the question and answer is about the hyposthesias that you sort of talk about. Can you expand on that a little bit about how you tell them and how you tell your patients or counsel your patients, and do they all get better, or do you have some that are continued?
Yeah, there's a couple that don't get better, and like any patient nerve combination, you'll have some patients whose nerves are a little more sensitive, I think, than others. And so I counsel them ahead of time that they'll often have some paresthesias, some numbness over the back of the thumb, and that typically goes away. But there are patients who it doesn't. Like I touched on it about the technique. Yeah, you don't want to aggressively cauterize or try to perform a neurectomy on those branches of the superficial radial nerve because you'll end up damaging the nerve itself. So you'll go all the way down to fascia, have your assistants lift up your flap so that you can theoretically be as far away from the nerve as you can. That seems to minimize it. But yeah, that's a potential complication.
Appreciate it. We'll move on to now we're going to try to address the joint a little bit. Okay, so we're gonna talk a little bit about some implant arthroplasties that have started way back. So we have the old filler stuff way back in the day with Swanson, trying to put material in there to replace the bones that we took out or replace the arthritic bones. Then we slid into, the biologic. We're trying to put, different things in there with the LRTI. And then maybe we're moving forward with some newer components. Whether any of these are all perfect, we're not sure. Just to go through history, Al Swanson, another Michigander, and I know Dr. Lawton's on, so I have to respect him and respect Michigan. There's a lot of early enthusiasm for this. Sorry, let me back up. A lot but what happened later on, as we all know, is, in the early 90s and late 80s, that we got the silicon synovitis. So you got this particulate debris that caused more problems. And it was a great idea. However, maybe the implant wasn't the best. Then we slid on to Jimmy Cal and some of his orthosphere, but sort of looking at models to reconstruct the joint, but not reconstructing it anatomically. Again, we jumped back and said, "Oh, we can resurface this. We can put some Artelon in." And the thing that happened with Artelon is the same thing, unfortunately, that happened with silicon, is we got reaction to it in a little silicon synovitis. So then pyrocarbon came in, and pyrocarbon was used in a lot of different ways. It was a little M&M or a little circle. Did that work? A flat plate that's used mostly in Europe. I don't think it got to the U.S. Then some hemiarthroplasties. But again, we're not doing an anatomic reconstruction. It's almost like we are doing a reverse shoulder before we had failures of regular totals. So we're using a reverse thing, and then that has problems within the trapezium. So pyrocarbon, as people know or don't know, if you do shoulders, it's something that's utilized in aerospace. It's very inert. It's used for heart valves, so it's close to the modulus elasticity of bone. So you may get some osteolysis, but maybe it was a design. So if you're trying to take a round structure and stick it in an area that's not round, which is supposed to be our normal CMC joint, then we ran into problems. The pyrocarbon in Europe, this was reasonably good. You're trying to slide in. It's not as old as the McKeevers that were done for the knees, but it's the same type of thing. You're trying to slide a little spacer in there, or as my patients say, a little gasket to clean things up. So there are some ones that are out there on the market. BioPro is one. I don't have experience with this. We have some people in the area that do. It's basically the same type of thing. You're trying to resurface. Bedia's got a great techniques paper I think it's techniques in upper extremity. There are some follow-ups that are not so good. I still think it has a little bit to do, and as again, I don't have any personal experience, but it has a little bit to do, or maybe a lot to do. You're just putting it in an area that's soft cancellous bone, and over time it's going to subside. So, is it better to get to the edges, sort of a Townley history of, make sure you're putting on the foundation, talking about total hips. So maybe that's the way this can be done, and this can be looked at. The Stable X is one that's out there. This one kind of reconstructs, sorry, got a dog in the back, sort of reconstructs the anatomy a little bit better. Just started in 2017, one surgeon study, very technical, extremely good surgeon who's doing this, but then we have other ones that are having problems. It seems to me to be a difficult surgery to do perfectly, but if you do, you're kind of reconstructing that area. With both of these procedures, you don't burn bridges. And that's one of the things about this, is that you have these two things, Stable X and BioPro, that get you better range of motion, maybe maintain some stability, and you can salvage them. But there's high revision rates and difficulties that can happen. And so are they the best? There's something to do. Maybe it's ones that we should do in the younger patients. Because when you do these arthroplasties and you do a resection arthroplasty and LRTI, it was great to do them in a 60-year-old, but nowadays we know that we're living to the 80s and 90s. Are we just accepting results? I have some experience with Ensemble, did not have any financial involvement, but do have some experience. So I'll talk a little bit more. It's the same type of thing. So, we've done about 60 cases trying to open this area up and resurface it, using again the pyrocarbon that we were talking about, trying to reconstruct the CMC joint in some way by resurfacing and saving the trapezium. Simple incision, as we've talked about before, using small broaches, rasping to the area, trying to reconstruct a nice area to slide it in. I've had 3 implants that we've had to revise, mostly because of me. As you look at the chart up to the top, they start out small. It's me being scared. Me being scared and putting in bigger ones. But it's just, it was my issue. So that putting too small of an implant, not actually cupping around the metacarpal is probably the reason. Resection, I've had enough patients that they had a resection the other side, and I had a conversation with them of trying to do something different, and most of them have been happy. One guy wasn't. No, I don't like it. I want you to take that bone out. Yes, sir. All right, we'll move forward. But all of them, when they did have a problem, were resected, and we had a bailout. The biggest thing that I see is if you have failures of resection arthroplasties or LRTIs, you see those great x-rays where somebody's fusing the first metacarpal to the second, like a salvage. We hope we never have to get that way. So this gives you an option. So the lesson learned is you got to size it. You got to put it in the right place. You don't want to end up with a chunk out of it like this one. You want to get all the way over to the second metacarpal. The good thing of talking on these things and talking to people like Harry Hoyne tried it, and Harry's got opinions before he does it, which is awesome because you always learn from Harry. Should you do a denervation at the same time? These may be in there for more stability. We're probably doing a little bit of denervation on any of the procedures we do around this area, but not to the level that Dr. Martineau showed. What are the questions? We don't have long term. It's only been there for 5 years. The shape probably means something. Don't have enough to look at it. And then the number of injections, steroid could cause problems. But luckily, on the revisions we've had, I've been able to have the resection arthroplasty, and you have a bailout. have a video online just to if you want to play with it, to look on AOS. Now, I got started, privileged of starting with um, Dr. McDonough, Kefauver, and Stern on a paper on CMC fusions back in 1992. And I was wondering, why I don't do them as much, and it's mostly because all these other things have come up. But I think it's something we should look at. People have better pinch, better grip. This is a quote from our paper, but essentially it's saying is they're limited, but they don't have problems. This is also, or they don't have complaints. They may have problems. Sort of like the same thing as the arthroplasties. They're not complaining, right? They got rid of some of the pain. They got a little denervation. But is it the best? Are we getting them an anatomic reconstructing CMC? Probably not, and obviously not in this one as we move forward. So there's been studies on arthroplasties, no real pain on function. People seem to be happier with LRTIs, seem to have more complications. The bottom line is the same as a PRC versus a four-corner fusion. One the non-union rate is 0, and the other non-union rate is low. But it does happen. So you do have to add another component to this to make sure things heal. So how do you choose your construct? Don't know. There's pyrocarbon involvement. StableX and BioPro is another one, but we've run into problems with it. High demanding is this high pinch. Should we be putting them in 40-year-olds? I know it's not across the board, but there's a lot of opinions about what you do in a 40-year-old. Do you resect the whole trapezium? Do you do a denervation? Do you try to do these things in between? The reason I kind of like this type of thing in the younger people is because you can revise and get a reasonable result. Not saying that resection arthroplasty is perfect, but it's pretty good when you look at the literature. So trends, and I borrowed this and stole this from Dr. Paxima, but you're just looking, what is the U.S. doing? LRTI, and I think we saw in the previous webinar that we were doing a lot more suspension plasties versus true LRTIs, and we're now sliding into the next level. And the next level may be some partial implants or into total joints, which we'll get to in the future. So I'm going to hand this over, I think, to Dr. Paxima. Nadir, I want to say thanks, and Dr. Wu, we got them in at last minute to help out. And just prayers are out to Kevin Chung, who had a medical issue and is doing well, from what I understand. Kevin was going to be on this, but we got a great backup team.
And Brent, there was a question really quick that said,
okay.
They said, what about the touch dual mobility implant?
That would be the greatest segue in the world.
Perfect, right.
That's next.
So thank you for the invitation, Brent. Appreciate it. So as I'm talking, I'd just like you to keep this case in mind and think, what would you do? You have someone with a Eaton stage 2 to 3 problem, and you're trying to figure out what to do for them. And so just as a quick refresher, this is the Eaton-Littler classification, and sort of think about it as stage 1 and 2s versus stage 3 and 4s. And there's lots of surgical treatments that you've heard about and that have been presented earlier. So if we go up the 2 arms of things that involve a trapeziectomy versus things that involve a total joint implant, as Brent pointed out, the LRTI introduced in 1986 has been very popular, maybe supplanted by the suspension plasty more recently. And so we're gonna look at this, not the top line, but the bottom line here, and take a look at silicone spacers, the Delacaffiniere total joint, pyrocarbons you've already heard about, then the cementless implants, and the more modern implants. So let me just, perfect. Okay, so the silicone spacers you heard about, I just wanted to keep this one slide in there. In '94, when I was a resident with Brent, he sent me down to Australia. And down there, one of the main problems with the silicone implants had been dislocation. So I got introduced to the idea of a silicone implant that had a hole in it, and you could take a slip of the APL and put it through it to discourage dislocation. But unfortunately, I don't think that ever took off. So this was the first real total joint implant, and this is in 1973. And it was the first cemented implant with a ball and socket design. And you could see you would cement in on the trapezium side. Um, the early results were great, but there were high rates of loosening and revision over time that made this implant less and less popular. If you look at the survival curve here, you see at 2 years the survival was greater than 90%, but over time the survival rate went down further and further. Next, people thought, well, let's try the cementless implant arthroplasty. So the cementless implant arthroplasty, you can see with some coating to encourage growth. And the idea was to, hey, let's get away from this cementing into the trapezium. The main issue has always been trapezial cup loosening. Just like when you're talking about total wrist arthroplasty, the main issue is always what do you do on the distal side, the loosening that occurs. So here's a comparison of a couple of these cementless implants, the Electra and the Ivory. And the Ivory prosthesis had a better track record than the Electra one, with a lower failure rate, lower loosening, and a slightly lower dislocation rate. But both of them, if you look, they have 5% and 4% dislocation rates, which were generally unacceptable. Again, there was a sharp drop off after 2 years in survival. And so these were not ready for prime time yet. Enthusiasm in the United States really went down. I mean, less than 10% of implant arthroplasties are done in the United States, whereas in Europe, it's 32%. They were still into it and willing to try new designs. So as a consequence, this is the modern implant arthroplasty that has come out, and it was introduced in 2018. The company is called Touch, and it's a cementless implant with dual mobility. So basically, it's like a bipolar. You know, when you're doing a hemiarthroplasty versus a bipolar. So the short-term complication rates were looked at in the single mobility versus the dual mobility. So a monopolar versus a bipolar, and there were 168 cases in one group, 184. So good, you know, about the same. And the follow-up was relatively the same, a little longer in the dual mobility group. And what they found was that the complication rate was significantly lower with the bipolar implant. And when you looked at the dislocation rate, there was a significant change in the dislocation. And that's true in the hip, just like it is in the thumb, because with a bipolar implant, you have a really big head inside the socket, so it makes it harder to dislocate. So which of these should we do with regards to implants versus trapeziectomy, denervation, all those other things? I'm going to just look at trapeziectomy versus implant arthroplasty. And there's been a few papers that have looked at this. And I'm going to start with this one, which is looking at total joint arthroplasty versus trapeziectomy. And what they found was that initially there were higher functional scores, greater range of motion, better pinch strength, and higher patient satisfaction at 3 months. So whenever I'm doing a basal joint arthroplasty, I always tell the patients, hey, you're going to hate me for 3 months, because it seems like it takes at least that long for most of their pain to go away. But the people who get an implant arthroplasty are pretty happy at 3 months. However, at a year, the functional scores and the patient satisfactions were about the same. The patients with the implant continued to have better range of motion and better pinch strength. And at 5 years, only the better pinch strength remained. Somehow there was also higher patient satisfaction, but these are interesting findings. So what was the main difference? The main difference was that there was a higher reoperation rate. So if you're doing a trapeziectomy, you know, we know that some of the complications that occur, we just accept. If there's subsidence, if there's some MP hyperextension, you know, you just kind of shrug your shoulders and say, this is it. But with an implant, if you have a complication, we're talking about a dislocation or a loosening, and that's going to lead to a reoperation. So there was a 2.5 times more likely reoperation rate with the implant, which has a lot of financial implications and something to really consider. So we can say that there's better early function and mobility, there's an increase in pinch strength, but there's going to be a higher reoperation rate. This was an interesting study. They just had 14 patients, so it's a small sample, but they basically asked them, hey, what would you choose again? Would you choose to have a implant or resection arthroplasty? And what they found was that 70% chose the implant again, and 7% chose the resection arthroplasty. Now, we only have 14 patients, so that means basically 7 patients chose the implant, 1 chose the resection arthroplasty, and 3 couldn't decide. So take that with a grain of salt. But the question is of value. And we want to know, is there a relationship between quality and cost? Because a total implant arthroplasty costs a lot of money compared to a resection arthroplasty. And so it really has to show that it changes quality significantly. You just saw this slide which looked at the LRTI's popularity. However, in this survey, we found that the LRTI popularity has just steadily been going down, while the suspension plasty popularity has steadily been going up, whereas this year, suspension plasty supplanted LRTI. There's been a lot of enthusiasm recently, a lot of news articles about first implant in America, first implant in Colorado, and so forth. And so there's a lot of hype around this, and people are coming and asking about it. We ended up doing one here at NYU, which I'll share with you. But these are some questions that I still have, which is the age. Is this indicated for an older patient or a less demanding patient, or is this indicated for a younger patient? In my opinion, this is going to mirror the total knees, whereas when I was a resident, you wouldn't think about doing a total knee on anyone less than 65. And now, regularly young people are having a total knee replacement. The revisions, do you convert to a trapeziectomy and just leave the stem? Or do you have to do something else, like add some type of ligament suspension to the procedure? And also, how much STT is too much? So I went to France and learned from these guys, and basically they sort of squeeze the wrist a little bit, and if it doesn't hurt too much, then it's okay to have a little STT arthritis. But we know about adjacent segment arthritis, and so that's a concern. Here we are with our case where we did a total joint implant, and the video on the left, you can see this is her at a week. So she was already regained full finger flexion, full opposition, and a decent movement of her wrist, and was extremely happy at 1 week. So time will tell how these things will pan out. Thank you.
Thank you, sir. We'll move on to Dr. Wu from Mayo Clinic.
Can you see my slides here? Okay.
Yes.
Okay, great. Well, thank you very much for the opportunity to be a part of this webinar. And my charge was to go into a little bit more of the technical details of the touch implant arthroplasty. I don't have any relevant financial disclosures. However, I will say that in our experience, this is still very early. So far, our patients have been happy. There's a wealth of European experience and data to support this implant. So I'm expecting us to stay on this peak. The other disclosure is that the learning curve for this is reported to be about 30 patients. So I'm still within this learning curve and just hoping to share some early tips that have been helpful so that your first 30 patients will maybe be a bit easier. Okay, so the touch implant is a dual mobility modular implant. So you as the surgeon will select a metacarpal stem, a neck, and a trapezial implant portion for each individual patient. For the metacarpal stem, there's 6 different sizes. For the neck, there's 3 different lengths. And for each of these lengths, there's a straight neck and then an offset neck that's at a 15-degree angle. For the trapezial cup, there's 2 shapes. There's a conical cup and a spherical cup. And for each of those cups, there's 2 sizes, so a 9mm and a 10mm diameter. For the trapezial cup, by and large, I'd say most of the surgeons in Europe and in the US are using the 9mm conical cup for patients who are the first time having the implant arthroplasty. The 10mm cup is really reserved for the revision cases. For the metacarpal stem and the neck, though, there's a variety of different combinations, and we'll go into some of more of the nuances of how you select one or the other. The indications we've talked about, so maybe to focus on the contraindications, we talked about symptomatic STT arthritis. So if there's some arthritis based on radiographs, but if the patients are not clinically painful when you palpate, it seems to be okay still to indicate them for the implant arthroplasty. Patients who have a trapezial height of less than 6 millimeters, there's not enough trapezium to support the cup, so that would be an absolute contraindication. They say that 8 millimeters of trapezial height is the recommended height, but up to 6 millimeters would be acceptable, and I'll show you a case of that later on. The last 2 are relative contraindications, so patients with generalized joint laxity, or if they're a manual laborer with a pinch strength more than 10 kilograms. With the touch implant, patients are reported to have stronger pin strength post-operatively. So being stronger than 10 kilograms or having joint laxity just increases the chance of having an implant dislocation. In terms of the steps of the procedure, the exposure is through your standard dorsal exposure to the CMC joint. The one thing though, you need to make sure you release everything around the metacarpal base. Keep the APL intact, but ulnarly you want to make sure you release the intermetacarpal ligament until you see the FDI muscle. This will be important later, more so for your exposure to the trapezium. You'll then resect the base of the metacarpal, and you want that cut to be just at the flare or the widest part of the metacarpal. It's about 4 to 5 millimeters that you're resecting, and your cut is going to be perpendicular to the long axis of the metacarpal itself. You'll then prepare the metacarpal canal. So this should be centered along the metacarpal in terms of the radial ulnar width, but in the dorsal third. That starting awl you can put in and you can twist and turn that all the way. But when you get to your broaches, you shouldn't be moving them or toggling them back and forth. You're putting them in either with a mallet or taking them out with a mallet as well. The reason is because this is a press fit implant, so you really need rotational stability and control of the metacarpal. You're not looking for cortical contact. You want some cancellous bone surrounding the actual implant. So the broaches that you use are also the trial, and this handle will turn off, and the broach that you use will stay in as your trial before you're putting in your final implant. So how do you know what is the right size? And this comes down to that rotational stability. So when you're turning the handle, the broach, and the metacarpal should move as a unit. There shouldn't be any ability to toggle that handle or the broach inside the metacarpal. And if there is, then you should size up. The other thing you can use to know if you have stability is you should be able to take the handle off, which is a twist. You should be able to take that off without the broach and the metacarpal also toggling as well. So you can use that to decide if that is the right size for your patient. After you leave the trial or the broach in, then you resect the volar beak, and that's to help avoid impingement. So that blue is just marking the segment that you would be resecting. I think what's also important in this particular procedure is knowing how to get the radiographs that you need to make sure that your implant and your K-wire eventually is well positioned and seated. So for the metacarpal, you want a PA and a lateral of the metacarpal so you can get your Kapandji views. I usually have my C-arm up and down like this. So for the PA view, the patient's nail plate is going to be parallel to the X-ray. And for the lateral view, their nail plate will be perpendicular. You can also check the sesamoids. On a true lateral, those sesamoids should be right on top of each other, so you should see them all as one. So you'll check your PA and your lateral view to make sure that the metacarpal stem is well positioned and well seated. Next, you'll prepare the trapezial surface. So you're just resecting the trapezial horns. You're not taking off the entire articular surface. It's just enough to create this flat platform to receive the trapezial cup. I think this is the crux of the entire procedure, is placing the trapezial K-wire. This will be the guide wire for your ventral reamers and then for the trapezial cup. Inside the set, it's called a fork. It kind of looks like a shoehorn, but you can put that underneath the trapezium to lift that up. And that also helps for you to depress the metacarpal down so you can see the trapezium. If you are struggling at this step, it means you haven't released enough of the metacarpal base or that intermetacarpal ligament. So that first initial exposure is really important for this point. Usually I move to the end of the hand table so I can see right down onto the trapezial surface. If you put a towel bump under the patient's wrist and ulnarly deviate, that will help as well. When you're putting in this K-wire and you're looking at the trapezium, you want to cheat it a little bit radial. If you look at the trapezium carefully, there's an articular facet ulnarly for the trapezoid. So if your implant is going to, or the trapezial cup is going to bottom out, if you're going to breach the articular surface, it's going to be ulnar. So when you're looking at the trapezium, you want to be centered and it's just slightly radial so that you're going to be centered on that proximal articular surface. And then you're going to drop your hand. The K-wire is almost parallel to the hand table to be able to get that angle so that you're perpendicular to both the proximal and the distal articular surface. Once you're happy with the K-wire placement, you'll advance it into the scaphoid so that you don't lose that. And then One point here in terms of getting that really nice view to check to make sure your K-wire is well seated and you're not breaching that trapezoid surface is the Betz frontal view. To get this, the patient's wrist is in neutral, slightly extended, ulnarly deviated, and then pronated down onto the X-ray, onto the fluoro. And that shows you that articulation really nicely. And it's important to get this view again, just to make sure that your K-wire is really well centered. So after that, you advance the K-wire into the scaphoid. There is a starting reamer that's a little bit more conical to help you get through the sclerotic bone. And then depending on which trapezial cup shape and size you're using, there'll be separate reamers for that. And you really want to bury the reamer fully down into the trapezium. And then the bottom video is showing putting in the final cup there and impacting that in. So it's a press fit as well. After you have the stem and the cup, this is where you're going to be trialing the various necks. I think this is where the 30 patient learning curve and learning what is the right fit and selection comes into play. I think it's just experience building and knowing what is the proper one to select. You want to look for 2 to 3 millimeters of laxity with axial distraction of the thumb. So that bottom photo is from one of Dr. Durings's papers. You can see the head of the polyethylene is almost coming out of the cup. So it's not really tight in there. You should be able to distract it. And at this stage also, the important thing is to actually remove all of your retractors. The retractors being in there will provide a bit of tension on that actual implant. So remove everything and then do your testing. Put the thumb through a full range of motion in flexion, retropulsion, extension, opposition to make sure that the implant is going to be stable. You want to know at this point if it's going to be unstable or dislocate. I think early on, I would trial all of the various necks just so that I had some experience in knowing how going up in length or changing the angle would change the stability. The offset necks will help you if the trapezial cup is a little bit malaligned from the metacarpal. It can help make up that distance. Talking to Dr. Durings, though, and some of the surgeons in Europe, if you look at a normal radiograph of the CMC joint, there's a little bit of an extension of where the trapezium and the metacarpal sit naturally, not just in patients who have that subluxation. So they actually tend to prefer the offset necks rather than the straight necks. But I think the most important is getting that 2 to 3 millimeters of laxity and having stability of the implant. Then you'll put in your final implant. And a few additional things just to think about as you're choosing implant size and patient selection. We mentioned that a trapezial height of less than 6 millimeters is an absolute contraindication. And the reason is because of the cup height itself. The 9 millimeter cup is 4.3 millimeters in height, and the 10 millimeter cup is 4.8. So you need to have enough trapezium to surround the cup. So for patients, this particular patient was 6.2 millimeters when we measured her. For patients that are borderline, you can consider a CT. And also, I spoke to this patient about if there was a iatrogenic fracture during surgery, would she be okay with me proceeding ahead with a trapeziectomy and suspension-plasty procedure? So I think that's a good conversation to have preoperatively as well in those patients where you may be a little bit concerned about the trapezial size. The other thing you can do is you can just take, when you're reaming, you can take the handle off and check with fluoro to make sure that the reamer is not going to bottom out, that you still have bone there. I was told also that you can leave it a little bit prominent as well. You don't have to fully seat it as you normally would, and the patients will still do well. The implant arthroplasty will restore some of that metacarpal height, so it will help with patients with MP joint hyperextension. If they're within that 20 to 30 degree range, I usually will stage them. And this patient, she still had a little bit of hyperextension on the fluoro, but clinically she was doing well with pinch, and she's not needed anything further since. So doing the implant and the touch, it will help you preserve that height and help with MP hyperextension. And then the last one is the young patient. This patient is 46 years old. She's trialed everything. We talked to her about various other options, including denervation, fat injection, other injections, and she had heard about the touch, done a lot of her own research, and had really wanted to go ahead with the implant. So I spoke with Dr. Durings, some of the European surgeons, and asked for their advice. And they gave me this advice to give to the patient in terms of counseling, which is the 10-year survival rate of a dual mobility. This is mostly based on the RP data, not on the touch, but also a dual mobility implant. The 10-year survival is 90%, and the 30-year survival is about 50%. So if you can give those numbers to a patient, she's 46. So when she's 76, there's a 50% chance that she'll still have this implant. The other consideration advice I was given is for younger patients to absolutely make sure that the neck is not too tight, because that will predispose them to having either asymmetric or just excess wear on the polyethylene. When they've gone back to revise it, though, the polyethylene ball is connected to that neck segment. So if the trapezial cup and the metacarpal stem are intact in good position, you can actually just revise the polyethylene by exchanging the neck. So still a fix for that as well. For her case, when I tested her at the end, she was still a little bit too tight, even with the shortest neck. So I actually resected back a little bit more on the metacarpal just to make sure that that it wasn't excessively tight, wanting to increase the longevity of this implant for her. So my take-home points are: make sure you release everything around the metacarpal, really take time with the fluoro and understand where the trials are, where the K-wire is, and convince yourself that you're happy with the placement before proceeding ahead. And then thoroughly test the thumb during the trial phase, both to make sure that it's the right size for the patient, and I think also for your own experience to learn what going up and down a size or changing the neck will mean for the final outcome clinically. Thank you very much.
Thank you very much. One of the questions, it wasn't with you, Dr. Wu, was about, but you did mention it, the whole thing about fat injection. I have no experience in that, and Dr. Martineau didn't talk about it. Since you brought it up, we'll put you on the hot seat. So have you done that, or what's your thoughts? So.
I personally haven't, but one of my partners here has. He's done an arthroscopic debridement and then injected fat at the same time. And in his experience, patients have done well for it. So it's something I talk to patients about, especially when they're young, just to give them all of the options. And my plan was to refer her on if she decided to try that. But some of the literature has been very promising in that, at least in saying that it's good for pain relief.
The other question that came up about doing implant arthroplasties and then ligamentous reconstructions. I've done 3 with the ensemble. I think it was more for my brain than it was for the patient, because they were shifting a little bit, and probably would have done fine. I think it's the same thing that you talked about. Getting the length back really kind of helps correct that dynamic MP hyperextension. I think there's a lot of that we have probably overtreated in time, but that's just my experience. I don't know if you guys, if any of the panel has experience with doing reconstructions, and we really didn't dive into the classic Eaton reconstruction on the type 1 or type 0 or whatever, or stage 0. But I don't know if I know you had a case. Do you want to just talk about that, or?
Sure. Yeah, I can do that. Let me just open that case up.
Because I mean, there's other options that are there. We moved into this total joint, which is really, really interesting. I didn't want to beat up the 2 of you, since the lead article in the Journal of Hand was complications. So obviously, it's, to me, this is just, the space is huge right now. I mean, I think that all of the industry in general has jumped over the wrist, they've jumped over the elbow, and they got to find something in the hand to do. So I always caution this, because we don't have long-term things that are out there. But it does seem that we're taking care of some of the problems that we just say that's the best we can do, and best we can do is sometimes very good. But just one. So, Dr. Paxman, sorry.
All right, so this is a case of that I recently treated. This is a young nurse who works in the OR, and she basically had a left thumb pain since many months ago. And on exam, there was quite a bit of pain and swelling in her thumb. Let me just skip ahead to this. So you can see when we're stressing her thumb, there was just a lot of pain right there. And what I noted was that it looked like she had some instability. If you look at the x-ray all the way on the right over here, you can see that the thumb wants to sort of slide out. And she had developed a small osteophyte. And this was more arthritis than you would typically see in a 29-year-old. So question is, what do you do with this case? So here's a Eaton stage 2 in a 29-year-old. And we sort of had a discussion about the various options, such as splinting. I really didn't want to do a cortisone injection in her. I think cortisone's a bad idea in young people. It's not good for the cartilage. PRP was a consideration, but as was brought up, it costs a lot of money. And in terms of surgical things, we talked about other options like scoping it or doing a ligament reconstruction. And so I'd love to.
So I would jump in. I'd jump in and do right now. I haven't done it yet, but I'd probably do an ensemble. I don't think I burn any bridges, and I'll get to stabilize it. Would I consider a denervation? I don't have enough experience in instability. Just in the ones I've done, it's not enough to say anything. But people are like, it still grates and grinds. It still moves over. So I'm going to turf this back to Dr. Martin now. It's like, in the ones that are unstable, are you still doing denervations?
Now, the patients with instability, they don't have as favorable outcomes. I've had patients tell me that they can still feel the sensation of their thumb grinding, but it doesn't hurt anymore, and they've been happy with that. But the ones that subluxate, like we're seeing here, yeah, those patients aren't as happy.
Dr. Wu?
Personally, haven't
Partner
done a
fat
lot
owner.
of denervations and for instability as well. I know from the wrist literature, they talk a lot about proprioception. So that would be my one question maybe for Dr. Martineau, if that's potentially a downside of doing a denervation for instability, is that loss of proprioception maybe.
I think it's a good thought. I think also why some patients don't have as much problem with proprioception necessarily as the deep branch of the ulnar nerve or your thenar branch of your median nerve might still provide some of that proprioceptive feedback, but yeah, they do not do as well. It's not universally a bad outcome, but it's a high enough percentage to consider something different. I don't know if the autologous fat injections here would be good, but again, you still have this instability causing problems, and then the shape of the trapezium. So
there's nobody on this panel that's going to look and do a touch on a 20 some odd year old. You get 30 years.
Yeah, 50
You just heard.
years, I guess.
All right, I'll go back to you, Dr. Paxton.
No, that's a good point. And, I just wanted to say also, David, on the ones that you've done the denervation on, have you ever gone back and do an arthroplasty? And if so, what's the dissection like? I'm picturing it kind of being like going back on a Xiaflex Dupuytren's with, once you've already done all that dissection, is there a bunch of scar tissue there, or is the dissection still easy to do?
The only added sort of care, if you will, is to protect the superficial branch of your radial nerve because there is some scar associated with that on the redos. I've done probably just over 100 of these and have had 6 redos. 2 ladies up to this point still have some paresthesias in that superficial radial nerve distribution. The other 4 are doing fine. So it's not like a bomb's gone off. It's not a terrible dissection coming in. So
yeah, I would say I've done some of the ensembles, not on Davis, but some other ones that have had previous procedures, and it's a little dissected, but it's nowhere near Xiaflex and Dupuytren. So that's a whole nother animal. So you can get to it. You just have to do it like you're doing a redo anything. You go to normal stuff and come back. So your incision may be a little bit bigger.
yeah,
but it's only history of, or only experience of maybe 2 or 3. So.
Good. That's good to hear. So basically, we also had gotten an MRI on her. I just wanted to share these. It doesn't really help much, but when you're looking at, we looked at some of the literature on this, and this is one of our fellows. So he had written an article about doing a ligament reconstruction, basically with 2 tight ropes. So that was another thing that we talked about was, should we do a tightrope in a suspension plasty? We can do a tightrope basically percutaneously, and maybe that would be a quick and dirty approach and stabilize things. But in the end, I decided against it, and we decided to do sort of the old school ligament reconstruction. And Dr. Glickel is one of our our staff, and he was, on the original paper with Eaton and Littler and those guys. So I asked him for some advice, and we ended up deciding to do a ligament reconstruction. And essentially, the ligament reconstruction involves obtaining a FCR tendon graft, and then doing a drill hole in the thumb. So here's an example of another case. It just happened that none of us had done one of these for a real long time, and then there were 3 that were done in the same week by 3 different surgeons. So here's a compilation. You can see the FCR going through a drill hole and then around the APL and then come back and tie back onto itself. And it did really produce a dramatic stability. And here we are with the X-rays, and you can see the drill hole that's going across here. And this is a video. Let me just play this video for you that demonstrates the instability initially that we can see, and then once we have the ligament laid down, it totally stabilized it. So be interested to hear your thoughts on this and any other suggestions on what you all would do.
Do you think you did?
My initial thought is you solved the problem of instability and denervated the joint. So well done.
I kind of agree, but
I seen that dissection. I'm like, yeah, you're heading in all planes that these nerves coming at. So
I was thinking the same thing when we were doing it. I said, hey, we're just throwing in a denervation for free here, because basically that's a dissection. But otherwise, on the denervation, I find it really hard to, unless you do exactly what you said, go take and expose the capsule all the way on the volar and ulnar side, you're not going to get a full denervation.
yeah, and even Dr. Kakar has a paper looking at cauterizing the capsule. Like he just burns the whole thing back and forth. I thought that's a pretty good way to make sure you're not missing anything.
I don't have any other questions. Dr. Wu,
One more case if we have time.
go ahead.
Yeah?
If they're not going to throw us off, let's play.
All right. Here we go. Let me see now. So here's another case, and continue to share. Okay, here we go. So this is a patient. She's 62 years old, with right thumb pain. Has tried a bunch of cortisone shots and splinting, and it's painful right over the joint. So you can see here again, not a bad looking joint, overall, but there's that medial osteophyte. So if you're thinking about a touch implant, you would make a resection right through here to flatten that trapezium out.
You do the same thing in Ensemble or a BioPro. Yeah.
And I remember talking to Orbe about this, and I thought that was a brilliant observation on his part, that this osteophyte just seems to grow and drives a wedge between the thumb and the index metacarpals, and just pushes that thumb out. You can measure the size of this osteophyte and correlate it with the number of millimeters of subluxation. It just seems that, like that, as it grows up there, it pushes out the thumb and slowly stretches out the ligaments. So she's 62, not a bad looking joint, a lot of pain. She's had a bunch of cortisone shots and tried a splint.
When you say a bunch of cortisone shots, what are your thoughts on that? How many? I mean, there's a lot of people come in the office and they've had 47 in the last week, but I mean, how many are you doing?
Yeah, I'm going with the 3 strikes you're out rule, basically. 2 or 3, no more than that. For no particular reason at all, other than that's.
I don't have any reason other than too much is too much.
Yeah.
David, do you have any thoughts?
I tell folks if they can stand the pain of the injection and it can last at least 3 months, we can repeat them at a mentor and fellowship that injected for like somebody every 6 months for like 7 years. That's a little extreme, but generally patients prefer not to repeat those injections too many times.
Dr. Wu?
I'm similar in that if they can get through about 3 months of relief, I don't have a maximum number, but do find that sometimes it's not as effective, and then patients for travel, other reasons, want a more definitive answer.
Once you've given them a shot, how long do you like to wait before doing a arthroplasty, implant or otherwise?
I'm at 3 months.
3 months. Yeah.
No rhyme or reason. I could find an article, I'm sure.
Yeah, that's what I do too. I probably learned it from you.
I'm sure I changed it.
All right. So, anyone, let's we'll have to stake our claim. What would you do with this? Everyone say what they would do, and then we'll see what I did.
Resect it and put an ensemble in.
Okay.
She would love her denervation. She's got no instability, subluxation. So yeah.
Yeah, she really has no instability, so she probably
Yeah.
would love it. Can't argue with that at all.
Her
Dr. Wu,
STT looks pretty good, so I think she'd be a good touch candidate.
she'd be a great touch candidate, right? That's what I was thinking. And so I was really just perplexed on what to do with her. So we ended up doing something completely different, which was to scope it. So I thought that since that osteophyte was the main issue in my mind, I convinced myself the osteophyte was the main issue. So I identified it, localized it with fluoroscopy, and then we stuck in a nanoscope, and this is a burr, and basically shaved down that osteophyte till it was nice and smooth again. And now it looks kind of like it's really ready for a touch implant. This looks like inside. It was a surprisingly easy scope to do. I've probably only done a handful of thumb scopes, but it's a very easy joint to get into, especially if you have fluoro available. I used the tiny needle scope, and you could see the full thickness cartilage defect here on the metacarpal side. And this is synovitis in front of the beak ligament. And then we introduced a shaver in there and was able to take down this is where the osteophyte takedown was. So recently I did a second one of these. This time I filled the space with PRP. I didn't do that on this one. We just resected it, and we're hoping for the best. So we'll see how that turns out.
David, so any thoughts on doing a scope with a denervation, or doing anything to the joint itself?
I mean, no, I just think that whole instability thing was eye-opening. I'm like, if the patient doesn't have advanced arthritis, but pain and instability, I think that's a combo that could be useful. But I've not scoped. There's some literature published on scopes with PRPs, scopes with fat grafts, scope with capsular imbrication. So all that's out there. I have no experience with it. I think when you're shaving down those spurs, Dr. Paxman, I mean, you're exposing that the subchondral bone, which I think is full of everything you'll get from your PRP. Anyways, maybe get some stem cells thrown in there for a good measure. But
that's what I was thinking too. Is like
yeah.
I was looking for an old Stedman pick to stick in there, but couldn't find it.
Yeah. But that's pretty good. Yeah, I would not necessarily see the utility in scoping, which is minimally invasive, and denervation, which is maximally dissecting.
Well, I appreciate your time. We're getting up to 9/11. Ooh, that's weird. We're getting up to 9/11, and moving forward. We got to make sure that Dr. Paxman gets some sleep because the Knicks are going to play again. And we appreciate everybody getting on. Dr. Wu, thank you at last minute. I know you were traveling and had some family, so thank you again. And Dr. Martin, now we'll keep you up for another couple hours since you're in Berlin. So you get the world and Olympic record for travel. So thank you, sir.
There we go. Thanks, guys.
Have a good day.